Rachel, and welcome.
Thank you so much for having me. I'm so excited to be here.
So great to have you. This is Rachel Schacht, and everyone, welcome to Into Motherhood. Rachel and I have known each other for a very long time, like really long time. I think,
Like
I think
probably
like over,
20,
yeah, 20 years.
yeah.
Probably over 20 years,
I
right?
think probably, yeah, I think probably over 20,
That's
which is
really
crazy.
crazy. That's so cool.
You,
Oh
you
my
can't
God.
say that about people these days.
I
Like,
know. So we were in
really,
NCSY together, and I'm originally from Ohio, so we were in Central East, and Rachel's from Detroit, and yeah, we started NCSY when we were really little. Like I was really young for sure. Yeah, like literally like 10.
yeah, so
Um,
definitely at least 20 plus years ago.
yeah, it was really fun. It was a really good time.
The best times ever.
It was actually amazing. Shout out to Central East NCSY.
Solid.
Amazing. Amazing, Sally. My own little introduction to Rachel is that Rachel is so much fun. It's like so much fun, so talented. I think that you did dance. Do I remember that
Yes, I
correctly?
danced. Yeah, my whole life.
Yes. Okay.
Mm-hmm.
Yeah, Rachel's very talented in the dance arena. And then now as adults, I'm getting to know you as this really like skilled, talented, well versed in physical therapy and specifically in pelvic floor at this point. So I'm really excited to talk to you about this. This is great. I'm going to jump in and read your bio, okay? Rachel Schacht is a doctor of physical therapy with specialized training in pelvic floor physical therapy. She lives in Sharon, Massachusetts with her husband and 2 kids. And Rachel has experience treating a diverse patient population, including pelvic health, orthopedics, post surgical recovery, and geriatrics. She has always been passionate about human anatomy and exercise science, which serves as the driving force behind the desire to help people overcome their health challenges through movement. Rachel, welcome to Into Motherhood. That was awesome.
Thanks, Julie.
Talk to us about your journey.
Totally. So we can start with like the credentials that are just like the sort of the basics. So going to PT school, it's a 3-year like doctorate program that's post grad, post undergrad. Once you finish that, then you can opt in to take pelvic floor specific training. So there are a few different avenues you can pursue in terms of like companies that offer the clinical training. There are two big companies. Um, the APTA, which is like they have a lot of courses to offer, and also something called Herman and Wallace. Either way, there are different tracks that you can take. You have to basically, in terms of both of those organizations, there is level 1 pelvic floor, which you need to take. And that is what you need to take in order to start treating patients. So, right, you've gone through PT school, you've taken your national board certification. Past that, then then you can take the you can take the pelvic floor level 1 certification, and then you can start treating patients Monday. So that is what I did. The other certifications I have are in orthopedics, different sort of like manual techniques, or manual therapies, treatments, dry needling. I've taken a few courses for that, but
Whoa.
there are other trainings in the pelvic floor umbrella that you can take for treating male patients, for treating complex patients. Oftentimes, for me, for example, I've learned sort of like a lot of the stuff on the job. So it's not like I'm like seeing patients and like guessing, but in having I think I have a very unique work team that we have lots of time for collaboration, complex case discussion, um, working together, trying, honestly, trying things on each other and teaching each other things. Um, because all you need is that level 1. So I don't have the formal male or complex training, but I mean, I don't treat male patients, but I certainly treat more complex cases.
Mm-hmm.
Um,
Mm-hmm.
so it really is just the level 1 that you need. There are also other more formal pelvic floor certifications that you can go through, and there's more testing, but that is not required to do this job.
Okay.
Yeah.
And I I did recently discover this, and I want to clarify it on camera also. OTs can become pelvic floor therapists as well.
Absolutely. So they
Okay.
go through a lot of these courses are offered to NPs, PTs, OTs, and
Okay.
probably someone in there, but certainly, I mean, I think that in if we're talking about OT versus PT, schooling is similar, but it's also very different. I mean, they
Yeah.
don't have the gross motor. My OTs are going to come for me, including my sister. But the gross motor training, the is just in terms of orthopedics is a little bit different. I think OT touches on a lot of things, but PT will go more into like lower extremity function and that sort of thing, which is really important for this work. So I think that OTs in this line of work have to work a lot harder to get up to speed on those types of things. Because again, we're treating not just the pelvic floor, we're looking beyond that and seeing, your lower extremity function, your deep core function. So it's just touched on differently and potentially less in OT school versus PT school. So
Hmm. Hmm.
that can be challenging for OTs, but there are plenty of extremely, extremely skilled OT, like pelvic floor OTs in this
Yeah.
field. So
Yeah.
they give a
And they
lot
are
more than we do in certain areas. So
okay. Yeah.
yeah,
And it's okay if anyone comes for you or not. Like we're here for some transparency, so it's okay. And they are welcome to come on and to talk from their perspective.
absolutely,
So we want
totally.
to hear from you now. Thank you so much for sharing all of that. That was really, really helpful. To know also just like the two big schoolings you said APTA
Yeah, there's the APTA and then Herman and
and
Wellness. These are
Menopause. Okay.
two organizations that offer like continuing education.
So that might be
And
something someone would ask potentially if they're like vetting
for sure.
someone. Okay.
Absolutely. Yeah. Yeah. You
Okay.
could say, like, what certifications do you have? Just curious.
Yeah. Okay.
Yeah.
Can you tell us where you worked before and then where you are
Totally.
now? Yes, thank you.
Totally. So I went to PT school at Hunter College in New York City. Um, Finished there and then moved to Boston once I got married to my husband, and then started working at Bay State Physical Therapy, which is a large chain in the Bay State area, so like on the East Coast. I worked in like outpatient orthopedics, where it's sort of like the typical like run of the mill PT practice that you can envision, an insurance based large operation where there's 20 tables in a big gym area, and you've got a few physical therapists running around treating a few patients at a time, kind of jumping from table to table, with machines and things like that. So that's where I worked for almost 5 years and loved it. Became a very well-rounded PT because I was, we see patients who are post-operative. We see patients who have an ankle injury, a knee dysfunction, hip surgery, spine surgery, concussion, um, neck pain, um, shoulder and arm dysfunction. So there's a lot. Like we're really looking at we're seeing everything in this setting.
Yeah.
So to have that experience and then move into pelvic floor PT was I thought was critical to my like evaluative process and also treatment. So to kind of taking a lot of what I learned working in that setting, applying it in pelvic floor PT has been amazing. The reason I moved, I mean, in school we had this hour long lecture. It was so interesting to me. I didn't even know that it really existed. And I was just like super intrigued, but just never sort of had the confidence to admit, like, oh, I can do this. I was just like, this is so cool for someone else. Like, how cool is this? But I'm just going to like do the classic sort of outpatient ortho thing. Then I got pregnant and then just became a little bit more educated. And I was just like, okay, I got to do this. Put myself through the training. It was like a weekend in Ohio, and then came back and started seeing patients through a pelvic floor lens. I got a lot of pushback from the higher ups in the company, And just logistically in the clinic, it was really hard to make work because, again, it is a really private, intimate thing. You want to create that atmosphere for the patients. It was not, it just didn't work well. So for that reason, I was starting to kind of look and just kind of like look at jobs. And a good friend sent me this listing and was like, this looks amazing for you. You should jump on it. And I did. And so that's where I'm working now. It's a place called Mom Life Health and Wellness. We are a pelvic floor PT clinic. We see male and female patients. We are out of network, so private pay. And we spend a lot of time with patients. We spend like an hour with each patient. And it's really, really, really good care. I think in the first place I worked, it was hard to give sort of next level quality care because of the time constraint and the billing pressure. You have to really try to bill for these things, and you want to be able to do it. Was just, insurance unfortunately kind of dictated a lot of what we did.
Mm-hmm.
um, Whereas in this field, we can sit and talk for an hour with a patient without laying a hand on them. And if that is what we think is the best for that hour, we're doing that. And we're
Yeah.
not bound um, by the expectations of the insurance. So it's really, there's a lot of pros. Obviously, it can be financially challenging for a lot of people. It's not feasible for everyone,
Yeah.
but it is well worth your money. I think, for someone who's interested and doesn't know, I think trying an insurance-based pelvic floor PT and seeing if you can get something out of it, that's totally worth it. It doesn't mean
Mm-hmm.
you shouldn't go in that direction, but if you feel like you've tried things and it hasn't stuck, or it's just you feel like they haven't gotten to the root of the problem, I would explore a private pay option where they're looking at you and spending time with you. We're just dedicated.
Yeah.
We're dedicated to solving the problem, being super communicative, taking the time to do that. Patients get better. They do. So
That's
it's really great.
that's amazing.
Yeah.
Wow.
So
Well, thank you for that. Thank you for that. There's a couple of things that you had said to me in our pre-conversation that really stood out that I wanted you to just like touch on for a moment as like to frame the conversation. So there were a couple phrases. What's normal versus what's common? What should we live with versus what we should work on? And do we have to live like X, Y, and Z? Those were like three separate phrases, but I feel like they're a similar theme.
yeah.
What are your thoughts?
So for patients, friends, people who I talk to about pelvic floor symptoms, um, I always preface, if the concern is something pelvic floor oriented or orthopedically, or ortho oriented, I'm having a conversation with people about what is normal versus common. So people will say all the time, listen, I've had a baby, or I've had an injury, or I've been through this in my life, and it's pretty normal to pee when I laugh, or I've had a baby, so it's really normal to have heaviness, or X, Y, and Z. Where and I'm quick to stop them, to correct them in terms of the language. It's not normal to have urinary leakage, to have fecal incontinence, to have pelvic floor heaviness. It is something that's very common in different stages of life. So it's really, and the reason why it's important and that I stress like that, like definition specifically, is because something that's normal is something that you should be okay living with versus something that's common. So to understand that these symptoms, while they're common, they're not normal, meaning you shouldn't have to live with them. There are interventions, clinical treatments, such as pelvic floor PT, that you can implement and practice. That's huge. You shouldn't have to live with this type of thing. So
Yeah.
that's why I clarify that, because I'm like, no, no, no. While it's common, it's not something you need to live with. So that's really
Wow.
important here.
Do you
Uh,
find that like patients, clients find that to be very empowering? Or are they like shaken by it?
Yes, I think so. I think they're like, and I think it like it encourages them and sort of reinforces the fact that like there is what we can do about this. You don't have to live with it. Like we can help you. Like these interventions work, with a thorough enough evaluation. We can get in there, give you individualized treatment that will hopefully resolve the symptom, the issue, the
Yeah,
dysfunction. So that's important
absolutely.
to yeah, it's important to explain.
Yeah, yeah. Great. Is there anything else you want to say on those, or maybe you'll also like weave it in, but if there's anything else that comes to mind before I jump in.
Totally. We can go on to the next thing. Yeah.
All right, let's do it. So we broke up our conversation in a couple different like topics.
We discussed talking about pelvic floor PT and interventions that we do into like sort of the lifespan. So we talked about injury based or sort of pre-pregnancy, if you will, dysfunction, and then we talked about perinatal dysfunction, which we talked about pregnancy, sort of postpartum, and
And then like
postmenopausal,
beyond.
like perimenopausal and postmenopausal. So
Yeah.
sort of like those like four stages.
Yeah. Awesome. And then now we'll delve into them.
Great.
So starting with pre-pregnancy, and I'm learning along with our audience here. There's some things that I know some a little bit more about, and other things less. So I'm going to just kind of bring up the topics, and then we'll delve into them and just take us with you, Rach.
Absolutely.
So we've got tampon pain. Maybe we'll start with that tampon pain, and then we'll move into pre-intimacy
Sure.
and intimacy wellness. But
Yeah, I
talk to
mean,
me
we
about
can
that. What?
absolutely. So
Yeah.
there's a lot of people who come to me who have not been pregnant, who are, who haven't gone through sort of this perinatal phase in their life, who are here, athletes, non-athletes, people experiencing chronic pain, or dysfunction post-injury. And a lot of what we see, at least in our clinic, is, pain driven diagnoses. So chronic pain, whether it's chronic pelvic pain, pain with penetration, which commonly includes like pain with tampon use, pain with
Hmm.
any sort of penetration, whether it's intercourse or not. Um, so there's a lot that we do with that. I mean, um, the treatment can be, in terms of something that is more chronic, what I try to explain to patients coming in, because they're often like, okay, like how long is this going to take? Like, what are we looking at here? The chronicity of the symptoms often determine how long we're spending with the patient in terms of the
Hmm.
intervention. It doesn't
Hmm.
mean that I need to be with you for a year or more. It's just you might need to implement these things independently for months plus, whatever that means. So, we're the the common treatments, and I'm just kind of giving a quick sort of like overview of this. It's often more complicated and more complex depending on what's going on. But for pain with penetration, whether it's tampon use, intercourse, etc., we're working on desensitizing the vaginal opening in the vagina itself and not spasming and contracting with penetration. So oftentimes, dilator therapy, pelvic wand use, desensitization of the area is something that we're working with patients on alongside them. So if people know anything about dilators, and you're maybe given the advice by a physical therapist to start using dilators, it really is hard to know how to do this, what to do, just sort of the prescription for dilator use without someone holding your hand literally and helping you to do that. So people come in with the dilators that I tell them to buy, and we're working together to desensitize the area and to work on the muscles in the vagina of the pelvic floor muscles that surround the vaginal canal to relax with penetration. So that is in a nutshell the treatment for penetrative pain.
Hmm.
The
Hmm.
dilators are a big are big players in treatment, but there's a lot of other things that we work on beyond the pelvic floor. So I have a model here that I can show. It's like my little paper model at home.
That's great.
We've got the white is all the bony structures. The white is the pelvis, and all of the colored, structures inside are the deepest layers of the pelvic floor here in this model. So we have the anal opening and the vaginal opening here that you can see. So when we work on pain with penetration that occurs vaginally, we are working in the vagina. And when we're working on pain with anal penetration, we're working anally. So there are different dilators for the two sort of openings that we work with patients in the clinic on. So we're working on trying to get the muscles that surround the openings to relax and give them length with penetration. So that is what we're working on here. So that is the pelvic floor, the muscles inside the pelvis. Everyone has a pelvic floor, male and female. But we're talking about like women anatomy.
Yeah. Yeah.
I know.
Got
So
it.
that
Got it.
is that. Sort of in a nutshell. That's pain with penetration.
And tampon pain, you would say, is a similar issue. It's
Yes, it is.
okay.
I would say it's like one and the same almost.
Okay.
Functionally, it's a little bit different because with tampon use, we're just inserting.
Right.
That's the end of the functional activity. Versus with intercourse, it's more dynamic.
Right.
So yes. So there's that differentiation. So what I was also saying was, yes, we're looking at the pelvic floor specifically and those muscles to make sure that they're coordinated and relaxed with penetration and not tensing up and doing the opposite of what they need to do. But we're also looking at the whole person. So we're looking at the muscles externally to the pelvic floor that feed into and around the pelvis, the inner thighs, the hip flexors, the glutes, the deep muscles of the core. We have to look at the whole body. And not just the body, but also like hearing from the patient, hearing from the client what their activities look like, what they're involved in, so we can give the right treatment based on the whole person. So it's
Wow.
really, it's not zooming in onto the pelvic floor. It's really taking a step back and analyzing like the whole body. So having an ortho background, I mean, you go through PT school and the pelvic floor is like at least 10 plus years ago when I was in school, it was like an hour lecture. It was like sort of like a special lecture. Now it might be more integrated into schooling, but it was very much a blip at that point in terms of education. And so really we're using our sort of more broad orthopedic training and looking at the whole body that way, and then integrating the pelvic floor as well.
Wow. Wow. So you really have to be a good listener as a pelvic floor therapist. There can't be gaslighting. There can't be invalidating. Like, you have to work together with the patient.
Completely. And oftentimes on our initial evaluation, I wouldn't say the majority of the time, but a lot of the time we are sitting and talking for the full hour. So I
Wow.
oftentimes don't even get the patient on the table. I'm like, it's so important for me to just, and sometimes the patient's like, I'm so sorry. Like, I spoke too much. Like, maybe I shared too much. I'm like, everything you said is valuable for me. I need to understand you as a person, what you do, what your stresses are, what your home life is like, what your work life is like, what your commute is like. I need to know everything about your life as much as you're willing to share, so that I can give the most individualized treatment to you.
Wow. Yeah, that's amazing.
So it's a very like special sort of like, you have to build that trust on day one. Be a listening ear, sit and look at the patient.
Yeah.
Sometimes I'm writing some things down, but I'm really trying to make the patient feel comfortable. And then that being said, sort of on a tangent, nothing that we do is mandatory in terms of the hands-on assessment. So I'm suggesting not to every single person, it just depends on what they're coming in for and what they're coming in with. But I'm suggesting potentially an internal pelvic floor exam, an external a pelvic exam, sort of that whole body exam that I was describing before. And if you're not comfortable with either one, you tell me, and either we hold off. You can also let me know when you're ready. Maybe you're never going to be ready, and that's okay. There's always something that we can do to influence, what's going on. So that's a really big thing to note for people who are interested. If your pelvic floor physical therapist is telling you you have to have an internal exam, it's a red flag. It's
Okay.
extremely important information that can help immensely. But if the patient is not comfortable, you're that's just it's over. You're not going to get anywhere. So building trust, working externally first and seeing what you can gather, and then creating a treatment plan from there, seeing how the patient responds. Maybe their
Mm-hmm.
symptoms are getting better. Okay, let's start there. So that's definitely something to note. Really important.
That's amazing. I think because that really could be a barrier. Some people might really feel uncomfortable to even go
Yeah,
to pelvic floor therapy if they're like, "Oh my gosh, I'm going to have to do this thing."
totally. It's
Wow.
totally not mandatory. It can give a lot of information, but not mandatory at all.
Are there ways to do like exams? Like, I think you touched on it, but just to clarify a little bit, like you can do exams externally as well.
You can get some information.
Okay.
Um, so if I flip this model around, it's showing there's 3 layers of the pelvic floor. This is layer 1. So there's muscles that you can palpate or feel externally. So um, ideally, we're not going through clothing, but we're to the sides of the openings. So I can assess sort of, let me get this unhooked here. So this is if you were looking at someone's vulva, these are the muscles that we're able to palpate and to assess externally. So, with a gloved hand, I'm assessing these maybe for pain, maybe for tension. Maybe I'm asking them to contract and relax and bear down and seeing visually what's happening from the outside. So I can get some sense of what's going on layer 1 wise. But I can't truly assess. This is the deepest layer again. I can't truly assess what's going on from muscle to muscle
Mm-hmm.
without being internal and it's with a gloved lubricated finger through the vagina for these more anterior structures. So
Mm-hmm.
yeah, so that is how I guess you can assess externally. But otherwise, right, we're looking at like inner thigh, glutes, deep core in the front, back muscles that all sort of attach and influence the pelvis. We're also looking thoroughly at the abdominal wall to see, how's the bladder moving? How are things feeling? Is there tension? Is there backup? Um, is there dysfunction? How's the rib cage looking? So it's truly so thorough. We're just looking
Yeah.
at these structures that do, I want to say indirectly, but directly play a role in pelvic floor function. So it truly is. There's so much to look at especially if the patient's, again, like I said, uncomfortable day one with anything internal. Fine, there's plenty to look at. There's plenty for us to look through. So that is another thing to note. If you're seeing someone and they're not looking at your whole body, how your hips are moving, what your abdominal wall is like, what your core strength is like, etc. I would ask about that. I have a conversation about, what else are you going to assess? I don't know.
So as you were going into everything, in terms of like anatomy, I couldn't help but jump to starting to think about pregnancy. And also,
Absolutely.
if you don't mind sharing, that you are also pregnant right now.
Yeah, we've got like a month to go. This is my third, and so I have 2 little kids at home. So it's exciting being in this field because I work with pregnant patients probably every day.
Yeah.
Um, Pregnant and postpartum, sort of the perinatal space. I work at a place called Mom Life Health and Wellness. in Medfield, Massachusetts. So it is very perinatal heavy, I think, because of our name. So we get a lot of women coming in who are pregnant postpartum, years postpartum, looking to get pregnant, trying to sort of get their bodies ready for pregnancy. So it is something that we deal with on a very regular basis at the clinic. Um, so it is really cool being pregnant while treating pregnant women, because it is a discussion sort of like back and forth. I mean, I really try to make my sessions very patient focused and not talking about me, but I think patients are interested in hearing, well, how are you doing? How do you deal with this? Do you have these symptoms? So I think actually it's nice to be able to talk to patients about what they're going through from a perspective of like, I've gone through it, so I can
Yeah.
tell you at least my perspective. I think that that can help sometimes,
Yeah.
whether it's calming or just giving insight. So it's been really exciting, and also selfishly amazing to work in a place where my own coworkers can just treat me. It's pretty awesome. So yeah, it's been really great. So yeah, definitely fun to share in that with patients. Actually, it's really funny. I have a patient who we share the same due date. So it's like she
Aw.
comes in she's like 35 weeks. Look at us. Like it's just cute. Like it's a very like friendly, warm setting. So it just kind of brings that energy out in patients. Yeah, I love where I work, basically, bottom line. But yes, it's been really nice to be pregnant in this line of work.
Yeah.
And in pregnancy, I'll explain to someone, whether they've been pregnant several times or this is their first time, just sort of like some of the physiological changes that like to expect. So patients can come in when they found out they're pregnant in their second trimester, in their third trimester, all throughout pregnancy. They can come in anytime. What I would encourage patients to do is come in before you're symptomatic, before you have anything going on, to sort of just get an assessment, have a thorough evaluation. If you're past 13 weeks, if you're into your second trimester, we are able to do, with your provider's consent, we can do an internal pelvic floor exam to give you insight into your pelvic floor. How's it functioning? Is it strong? Is it tight? Is it weak? What's the deal? And here are things that we're recommending based on this assessment that you can do. Again, of course, if you're not comfortable with that internal assessment, we can assess you externally, and also talk about some of the changes that are there that typically come up in terms of postural changes, in terms of weakness, in terms of some like strength issues that we often run into. So here, we can kind of spell it out. Here are things that would work for you, that based on your assessment. If you want to try that and come back to us in weeks, months, whatever it is, great. Some people like to have, even if they're not symptomatic, some people like to have that. I'm blanking on the word, but some people like to have that consistency of coming in just to get an assessment or a reevaluation every X amount
Mm-hmm.
of weeks or whatever it is, once a trimester, maybe more. And we can reassess and update the program. And then oftentimes what we're doing in the third trimester is like birth prep, like push prep and birth prep. So we, at around 33 weeks, we start something called perineal massage, which is, the goal of that is to give length and basically trying to relax the muscles that feed into the perineum. I'm going to pull my trusty diagram out again. So here, again, vaginal opening and anal opening. Here is the perineal body, aka the perineum. So the muscles that feed into this, we want to make sure that not only is this structure flexible and and you can connect to and give length to, but the structures that feed into it also, they're not pulling, and they're able to lengthen, so that they're not influencing the perineum to be stuck and tight.
Mm-hmm.
When the baby is coming out of the pelvic outlet, aka the bottom, the vagina. We want those muscles to not be strong. We necessarily, that's not the goal. The goal is for you to be able to tap into your pelvic floor and give it length so that it can move out of the way so the baby can come out.
Mm.
Uh, with ideally less perineal damage. So we talk about like tearing and perineal tearing.
Mm-hmm.
Perineal massage can, if done sort of properly, and for a good length of time, so 33 weeks on, can reduce the risk of severe tears. When we talk about severe tears, we're talking about tears that go down to the anal sphincter and through the anal sphincter. The perineal massage does not reduce the risk of tearing, period. So it is something to consider, to heavily consider. It's also, so not only is it helpful in reducing the risk of severe tears, but it also helps the patient learn to breathe and lengthen through pain. When we're physically doing this massage and trying to give length to these tissues, it's uncomfortable and it can be kind of painful. So being able to cue the patient, okay, think about this with your exhale and seeing if you can tap into your pelvic floor with a cue, like a mental cue, or physically making a low tone noise. That's something that we utilize a lot in terms of push prep. Try this noise versus that noise, and I'll give you feedback, and maybe you can see if you can feel that. Do you feel your muscles lengthening? Do you feel this part of your body lengthening when you exhale and make this noise versus that noise? So we're giving them things to try. I often will have people go home and I'm telling them, sit on the toilet, make these 5 sounds when you're pooping, exhale when you're pooping, and what is the most productive for you? Does this sound versus this sound help you relax your pelvic floor most when you're pushing? Practicing pooping with this mantra is a really functional way to prep for pushing.
Wow.
So it sounds crazy,
Yeah, it
but
does.
today, so it's like nothing for me, but it's, it's a very functional like practice for
Yeah.
people.
What's
So,
if, unless it's like weird to say, but like it's like sounds or it's words like.
yeah, so some of these low tone noises that we teach people to try. I'm just going to give you examples. It's
Okay.
mooing, like a humming, shh, grr, and I think I'm probably forgetting a few, but we have people take an inhale on the exhale, shh, or ooh. I mean, it sounds
Wow.
crazy, and I'm like, maybe in the privacy of your own home you can practice this. Like, you're not going to practice like at work, like in the stalls next to your coworkers. I
Yeah.
mean, go for it if you want to, but and you can see, oh, I'm actually connecting most with this sound. Connecting meaning relaxing. Another
Mm.
way you can try it on the toilet. Another way that I have people try this is sitting on an exercise ball, where you actually like spread your cheeks and sit on it, and you can feel your pelvic floor relax into this ball, and then you can try to exhale and make those noises and see what you feel, because the ball giving feedback up into your pelvic floor, it's easier to feel, oh, my pelvic floor is actually relaxing versus lifting off this ball. So it gives you that tactile feedback that can be helpful in determining, actually, this is the most productive for me. So,
Wow.
yeah,
Got a tough job because these are very like
it's just
intricate
intimate.
areas. What'd
Yeah,
you say?
it's intimate.
Very intimate, but also it's like crevices. It's difficult, and it's not like my knee. Like you can't just
Right.
like bend it, open it, look at it, feel it, touch it. Like it's not
Right.
as easy to just do that. You have to have like skills that are a little more like intricate. Yeah.
Yeah, there's definitely some fine tuning and attention to detail that's really important in this fields of work, whether it's um the muscles they're small in the pelvic floor, and it's hard to differentiate, but also just like the details of like the patient's facial expression, like I don't, like, without them telling me something, I'm trying to gather information without them telling me necessarily. So just being very patient and slow and attention to detail is really important in this line of work. Um,
Yeah,
so patience. Yeah,
absolutely.
patience with patience.
Absolutely. So it really gets me thinking then, like you're talking about preparing and like lengthening. God willing, birth should go successfully for people. Unfortunately, there are sometimes some side effects, like people's birth fears, episiotomy, tearing. So talk to us about that part.
Absolutely. So I think, I would say perineal tearing is very, very common postnatal delivery. Sort of we talk about grades 1, 2, 3, and 4. 3 and 4 are considered, more severe, and in the grades 1 and 2 tears are on the more mild side.
Mhm.
And it is, to simplify it, it's just the length of the tear and how far it goes. You don't have to, it's not just tearing down. You can have tearing up. But when we're talking about the classic grades 1 through 4, grades 1 and 2 are just sort of like above a grades 3 and 4 in terms of length of tear.
Okay.
Um, so so that is perineal tearing, again, which is very common during birth. When we're talking about episiotomies, are often these days less common. We're seeing them just like happening less. That is an incision made by the doctor to open up to create more space for the baby to come through. So
Yeah.
it's a forced tear. It's a tear that was done surgically. And then in terms of forceps or vacuum, so like forcep or vacuum assisted births, they have a risk for increased perineal damage and tearing. So, it can that can happen for a number of reasons. Bottom line is the baby isn't able to come through in, you know, fast enough or efficiently. The baby's getting stuck. So they're either doing an episiotomy or using sort of the vacuum or forceps assisted mode to get the baby out. So yes, that can lead to perineal damage. So postpartum, when we see patients, they're often postpartum. We typically, at least in our clinic, we're seeing patients before they're medically cleared at like the 6 week mark. So we see them at like 3 or 4 weeks postpartum. If we're talking just strictly vaginal delivery, what we can do at that point, right? They're not cleared for exercise or anything internal. So like you can't have intercourse. You're not exercising quite yet. We can assess you externally in sort of the ways that we talked about before, give you basically exercises that are safe to do pre-clearance. So I think a big misconception is like, I haven't been cleared for exercise, therefore I'm going to sit and I'm not going to do anything. It's not going, it just, there are things that you can do and are things that you should do, because during this time, your body is at its weakest and you're having to do all of these new things that you've never done before. Caring for a newborn while recovering from something like this is just like, it's totally this brand new thing. So preparing your body in ways that are safe to support yourself during this time is huge. So we see patients as early as things come up, but often if we're sort of like, if I'm with a patient that's pregnant and we're thinking about booking out postpartum, I'm often having them book around 3 to 4 weeks. It's pretty early to come into a clinic. Some people are like, I'm in this acute tailbone pain. I can't walk. So I'm going to come in at 2 weeks postpartum, or I'm going to come in a week later. Sure, those are more rare. We do see them, but I would say for most people, they're not really ready to leave their house before 4 weeks. So oftentimes we're seeing them around then.
Yeah.
If they're not feeling like they're up for that totally understandable. We can see them after they've been cleared at like 7, 8 weeks, where we can do an internal pelvic floor assessment, give them individualized feedback, and start them on a program based on what we're finding. So, in light of the tearing and the perineal damage at this time, what we are doing is desensitization of the tissue. So the scar tissue, once it's healed and once you're cleared, we can work on actually releasing some of that scar tissue so that things like penetration are less painful. Oftentimes when there's scar tissue at somewhere, that the area around there is more sensitive. So often, a lot of times people are post perineal, whatever perineal level of perineal damage they have, they're having a lot of trouble with initial penetration. That is really, it's really painful, or it's really uncomfortable. It's irritating. It's a problem for them. So we're doing desensitization work to try to not only desensitize the tissue around that area to be less sensitive, but we're also trying to physically break up the scar tissue once they're cleared and once this healing is done, so that the tissue is more pliable and it's not so rigid, especially right at the opening of the vagina. So we're doing a lot of like physical massage release work to get the scar tissue to break down.
I have a few questions though about that. Like the scar tissue makes it tighter. Is that part of the issue? Like, okay.
Yeah, I mean, scar tissue is just inflexible. It's rigid, it's tight, and it can be sensitive because of the sort of the nerve endings that have been cut through in that area. So we're trying to desensitize the area. Where I can jump to post C-section during this time as well. So
Right.
we talk.
It kind of, yeah, it goes there. Yeah, why not? Why not? I'm curious about that in terms of scar tissue. Real fast before you jump in there. Scar tissue, what exactly is scar tissue?
So scar tissue is tissue that has been developed after there's been like an incision, or okay, basically scar tissue is this disorganized layering of tissue that is formed around, like in this case, an incision, and it's often hard, disorganized, and tight. It's not skin, it's deeper. It's, well, the scar tissue can be skin level, but it's often, sort of this deeper tension. It's just this tissue building around a wound or incision. So
Okay.
that's what it is. So it's tight tissue.
Okay, got it. So with that in mind, then yeah, let's jump into C-section recovery.
Yeah. So during this time, if you've had a C-section, we are really, really looking at the scar there too. So once you're in the beginning, before you're cleared, we're looking at the scar we're looking at it from like a healing perspective, seeing, is there any are the steri strips still on, is the bandage still on there, are we that early, or if we're often not taking that off. Let's say you're 2-3 weeks out and you want to come in and you do have steri strips along your scar, or the tape still, the is sort of the tape still on you from the surgery. We are addressing the scar but above the scar. So we are addressing the scar via the abdominal wall. So inches above where the scar is, we can start to influence that area, which should influence the scar inches below. So sort of like swiping in different directions, different textures. We start with like light, soft textures, like a cotton ball or a makeup brush or a tissue. And we are swiping along the skin in different directions to sort of bombard the skin with different sensation of like, this is different, a lot of different stuff, but it's safe and it feels okay, and we're not in danger. So we're trying to, again, desensitize that tissue. Once we can, we can get pretty close to the scar, we're just not rubbing at such an early stage. We're not rubbing along the scar itself. Maybe we can tap along the scar versus really kind of pushing into it, but we're working above and then gently along and below the scar onto the pubis. So that is part of what we do. And then over time, you can get a little bit more aggressive with that, and use more sort of like harsh textures. So like maybe a paper towel, maybe a hard sponge, maybe a comb, to really, again, bombard the skin all over the belly and then at and below the incision itself, with different sensation. The reason, again, functional reason for that is oftentimes, with skin that's really sensitive, that just like isn't touched, it can just be sensitive to air. I have a lot of patients telling me, like, if I'm near like like AC or like wind, like it hurts me. So
Wow.
we need to do desensitization work. Oftentimes we're also dealing with patients who are like, I can't wear any tight fitting pants or forget jeans, forget leggings. I can only wear sort of high waisted, like stretchy pants because I can't have anything pressed up against me. So functionally, that's a problem. So, for those reasons, it's also really important to do this desensitization work so that your sensation is good and you're not hypersensitive to things on you.
Yeah.
Um, Another reason why it's important to address the scar is because tension from the scar tissue, which is important for healing, it's incredibly important to let that heal and let the scar tissue do its thing and bind down. Once you're healed, we can become more aggressive and work on the along the actual scar. So we want to, again, once you're cleared, start to work on loosening the scar tissue and decreasing the tension along and around the scar so that the scar tissue doesn't, I feel like I say this word and it's kind of creepy, but like leach onto surrounding structures.
Mm-hmm.
So oftentimes, it can have an influence on the bladder because of its proximity. It can kind of be influencing the bladder maybe in one direction versus the other, depending on where your tightness is along the scar tissue, along the incision. It can influence hip flexor tension. It can influence the pelvic floor. A lot of people are like, "Whew, okay, great. I had a C-section. That was a trip, but my pelvic floor should be totally fine. Like I didn't push a baby out of me." Unfortunately, a misconception. There's a lot of influence that scar tissue in the abdominal wall, whether it's from a C-section or any other sort of abdominal surgery, can have on your pelvic floor. So really important to address that to get ahead of any pelvic floor related dysfunction that could come up from this tension at the level of the abdominal wall. So that's another thing that's really important, to note during this time.
Yeah. Wow.
Yeah.
Oh,
So that's like
so much.
immediate postpartum.
What'd you say?
That's like immediate postpartum, C-section versus vaginal, I would say.
Mm-hmm. Mm-hmm. Do you do the same thing for perineal post if it's episiotomy or if there's tearing? You also break up the scar tissue?
Correct. Yeah.
Okay.
Yeah.
Okay.
Yeah. The
Wow.
treatment is pretty similar there in terms of like scar tissue breakdown in a safe way.
Yeah.
Uh, so yeah, we're really working on, that in the clinic. I'm giving them exercises and stretches they can do on their own at home. There's a lot to do between sessions
Mm-hmm.
to get some good carryover. So yeah, that's a good question though. That is similar.
Thank you. With perennial tearing and with C-section recovery, I know that there's differences, but there also seems to be similarities in terms of the scar tissue. When is too late? Is there too late for, massaging it?
Good question. I think early intervention is best in terms of getting ahead of it and, potentially making the process quicker. But I have patients who years later are coming to us and saying, listen, I've had dysfunction and pain. I had a C-section years ago, whatever it is, months, years, whatever it is. Um, what can I do? We can make change on old scar tissue. It is definitely harder, can take longer, and maybe the potential for change is less, but there still is potential for change. through a lot of different modalities, whether it's hands-on manual work or, dry needling or stretching, things like that, proper breathing mechanics. There's a lot that we can do to influence scar tissue. So
Yeah.
at any stage, you should be able get to make progress
Hmm.
wise. Yeah.
Yeah. Wow. Thank you so much for that. That was phenomenal. Are we, I'm just like, oh my gosh. Are we, do we feel ready to move into, I wrote it down as postpartum.
Yeah. Like
um,
the slightly later years.
Slightly later years.
Something important to note is that, so we're going to talk about sort of perimenopause into menopause time. Um, Something important to note, a few things. So when you're postpartum, it's sort of like a mini perimenopause time.
Oh,
The hormone fluctuation that people experience postpartum is very similar to perimenopause. Perimenopause is, this is not a formal definition, but it's defined as these peaks, these sort of random peaks and valleys of hormones and crazy hormone fluctuation that can lead to things like hot flashes, mood swings, and genitourinary symptoms. Those symptoms are like the pelvic floor related symptoms, specifically vaginal dryness and irritation of the vulvar tissue and the vaginal tissue. The reason why that happens is with dips in estrogen. So especially when you're breastfeeding and postpartum, your there's this big depletion in estrogen, and a lot of people are coming to us reporting vaginal irritation and dryness and a lot of pain with intercourse. Um, so something that we can work on, something that basically will suggest, and I'll suggest to patients, is have a conversation with your provider potentially about topical estrogen. So that is something that can really, really make a big difference in terms of these types of like vaginal dryness, irritation symptoms. And in a lot of cases, can just solve that problem. Not to say that pelvic floor PT is not something that they need to do, potentially, yes. But that can be a big, big player, especially in this sort of acute postpartum time. It's something people just don't know about. So I think talk to your provider. They have your, they have access to your full medical history. They can assess medically if it is safe for you to use a topical estrogen during this time. In most cases, the answer is yes, but you're going through your provider, and they should be able to provide a sound medical recommendation.
mm-hmm, mm-hmm.
That's a big thing that we'll do. We'll work with patients while they're using the topical estrogen and giving them stretches and exercises to support the goal of lengthening, relaxing the tissues, while the topical estrogen is providing really a plumping and a moisturizing and lubricating effect. So that is huge. That can be
Yeah.
really, really
Wow.
huge.
Thank you for sharing that. Thank you.
So that
Um,
is sort of like acute postpartum, like this
mhm,
like faux perimenopause time. Looking forward into the perimenopause and menopause sort of years. Perimenopause, again, like I said, it's peaks and valleys of your hormone levels, and then sort of marked by like irregular periods and some of those other symptoms that I talked about. Um, and and then once you haven't had your period for 12 months, you're officially in menopause. So, and then you're postmenopausal. So when you're in postmenopause, um, a lot of these symptoms are, so now the hormone levels, the estrogen is, there's just a depletion in estrogen. So that is a big part of menopause. So a lot of what we're doing with that population is working on maybe they are on hormone replacement therapy and maybe not. Either way, during this time, estrogen depletion can not only affect the lining of the bladder, the pelvic floor musculature in terms of how dry, irritated, and weak and thin it is, but it also affects joint health, um, muscle bulk. So we're working on strength, balance, generally, plus also addressing some of like the vaginal irritation and the dryness and the pelvic floor sensitivities. So
Mm.
um, we're working with patients to battle prolapse, to battle incontinence, whether it's fecal or urinary incontinence. We're working on pelvic pain, pelvic floor discomfort. Those are a few examples of some of stuff that we are often addressing during that perimenopause and menopausal times.
What, just define for me, exact, like menopause means what? What exactly does that
Menopause.
mean?
So in perimenopause, there's peaks and flows of the hormones. And then once you hit menopause, the hormone levels drop. So now
Yeah.
you're in this, the estrogen levels are decreased sort of significantly, and they don't jump up and down anymore. They just stay down. So now this woman is going through um just sort of these changes are just they're just at a constant now. It's not like getting better then getting worse, getting better, getting worse. It's just staying low. So, joint health, pelvic floor health, um, strengthening, balance work, that's all really important to do on a regular basis to sort of battle what's happening in the body and what's staying at a constant.
This must be, and so I thank you for answering my questions because it really, some of it really is so new. I'm just really trying to understand it. Like, this must be when the framing of the conversation piece really comes in. Do you have to live with this? Just because it's common, does that mean that this is normal? I'm sure,
Totally.
like, because it just, and it's probably so challenging. I just know, I just have an idea that it might be because I'm a woman and I've dealt with healthcare issues, that it's probably very challenging for women sometimes to even validate themselves enough that something is wrong that they have to go see someone.
Totally. I think people are they're in I think it's a population that really is underserved. They're like gaslit a lot, being told, "Oh, hey, like this is normal for someone your age," but there's a treatment for that. You shouldn't have to live with these symptoms. These symptoms, yes, they are they come with this time period, but there are interventions that are safe for you that your doctor can and should provide you. I mean, of course, they're looking at your medical history to make sure that there are no contraindications for you specifically, but there are so many options based on your medical history that something you should be able to find some solution medically um to address your hormones, and then sort of doing all these other in terms of the PT stuff on top of that.
Yeah.
So yes, it's really, and it's like if you're not sleeping, if you can't function, that is a hallmark symptom during this time. So that shouldn't be poo-pooed. I mean, if you can't, a lot of people feel like they're going nuts. They're going crazy. They're like, I can't sleep. My mood is crazy. I'm in pain. I have like joint achiness. Like, what is going on? Well, you're in this phase of life now. And absolutely it should be brought up to your provider, because there's so much that can be done for someone.
If people go to their OB with this kind of thing, are they going to get the same response as if they're going to straight to a pelvic floor therapist? Like, how does that work in terms of bringing up these issues? Because some people might specifically just go straight to an OB. Like, why
For
wouldn't
sure.
they?
Absolutely.
So, but like, what are they getting from that versus going straight to you? But maybe they don't know who to go to you yet.
Yes. I think, we can provide different things. So, I mean, PTs can't prescribe medication. So you could be a candidate for hormone replacement therapy, HRT, in some, in some capacity, through your doctor, and that can be supported with PT. It doesn't mean every woman who is in this phase needs to come to pelvic floor PT. But I think it's, sort of addressing the hormone disruption, or hormone variation is huge. And that often is like sort of the foundation. And then there's other things that you can do to support yourself in this time. So, if
Mhm.
someone's coming to me and has not spoken to their doctors, I'm urging them to either, or maybe they've been dismissed by their doctor. I'm giving them recommendations of who they might be able to go to, someone who maybe has a menopause certification, who maybe specializes in, women's health, that sort of thing. So I'm urging them to go find someone or go back to their doctor, have that conversation, and if they're based on what they're reporting, symptom wise, I'm advising them to maybe come back to me, or I'm saying, go ahead and start that, and then we can kind of be in touch and see how you feel.
Mhm.
So there's a lot we can do to supplement them during this time, but I feel like oftentimes, um, addressing them hormonally, which is not something we can do, it's something their doctor could do, is really a foundation. So that's
Yeah.
really important to start with at a baseline.
That sounds like a really nice perspective coming that is coming from you in terms of your disposition towards doctors. Like because sometimes there can be discrepancies in care, and which we discussed slightly on episode 2. So feel free to tune in there, guys. No, but like it's real, but we didn't at the time. No, that was more about that was about pediatrician and like
Sure.
kids. This runs the gamut though. That type of discrepancy is going to happen in any part of medical care. So it's cool though to hear you say that like you're partnering with the doctor.
Absolutely. I feel like, what we like pride ourselves on is our community that we've like created. So we're trying to provide our patient population with this well-rounded, community of providers. So, we have strong connections with like lactation support in the area, with mental health therapists, with dietitians, with OBs. We To be able to give the patient information where they might need it. So yeah, it's huge for us to partner and make good connections with, like trusted OBs and providers, so that we can, oftentimes these people are coming to us and they're like lost. They just like have no idea. They don't even necessarily, people don't always necessarily identify certain symptoms with a certain profession. They're like, this is what I'm dealing with. Like, how can I be helped? So it is really helpful for us to be able to have that network that we can, specifically refer to.
Oh,
Um,
amazing. Sounds like a dream.
it's
Sounds like a
huge.
dream.
It's
That's
huge. Yeah. So
amazing.
it's pretty cool. It's
The
pretty cool.
vision is beautiful and it sounds like it's in action. So that's
It's great.
wonderful. Well, thank you for going so deeply into all of those things. I definitely learned a lot. And we're way over an hour, but if you're okay with it, I would love to continue a little more and talk
Sure.
personally. Um,
Totally.
so we'll dabble a little bit of chit chat,
You're allowed.
but also no, but like real, I'm going to ask you some real questions if that's
Great.
okay.
Let's do it.
So Rachel, talk to us about your experiences and how your pregnancies and your role as a pelvic floor therapist and also as a physical therapist, how it's intersected. What is that like for you in terms of also like how your pregnancies have gone and deliveries?
Yeah, I think again, I feel lucky to be in this field because I have this like bonus education, um, on sort of again common versus normal, what to expect, what the quality of care should be for someone who is going through any of these life phases. So it's been really unique as a woman to be able to again have this education, have these experiences, being able to help people who are in my shoes.
Yeah.
Um, so it's been really, I just feel really lucky. Um, and it's been really cool. I mean, talking about sort of my like getting into this profession, um right, like I started sort of generalized ortho and then became pregnant. All these things started to happen and I was like, I gotta get more information, not only for myself, but this is like just such a special population, sort of underserved, misunderstood, maybe gaslit. So to be able to serve this population has been extremely, extremely rewarding. um Physical therapy is very rewarding, but I think even more so in this field because it's so personal and we're talking about things that are so sort of untouched. So
Hmm.
it's really unique and very special, and I feel very lucky to be in this field.
Yeah, and such integral parts of the body for
Right.
everyday function that we don't even always realize.
Yeah,
Um,
exactly.
Talk to us about your pregnancies and deliveries, whatever's comfortable to share, and what might shed
Totally.
light on things for us
Yeah,
that might be helpful to someone else to hear.
absolutely. So with my first pregnancy, it was COVID. So it was just a really interesting time to have to be pregnant, especially for your first time, for the first time.
Oh my gosh,
So
that must have been so crazy.
it was it was definitely a wild time.
Yeah.
Lots of fear, lots of unknowns. I was not in this field at this time, so I just had like so many unanswered questions. I did feel quite lost. I didn't see a pelvic floor PT until after my second, because once I was in the field, I was like, great, I'm just gonna like, I know exactly where to get treatment, and I know what to expect and what to ask for. So very lucky in that way after my second pregnancy. But I mean, I was told at like 37 and a half weeks that the baby was breech and sunny side up. And I was like, whatever that means.
This
I
was the
don't know.
first pregnancy.
This is the first pregnancy. So I went in for a version, which is it's the external version where they try to like kind of turn the baby externally through the abdomen, which was unsuccessful. So baby stayed breech, had a C-section, which was really disheartening. I mean, I knew, I didn't know much, but I just knew that I didn't want a C-section. So I think, you know, so I think getting over that was tough, but in sort of my education into this field, I was able to sort of like do what I need to do to address some of the dysfunction that I was going through. And then by my second pregnancy, it was really looking forward to like a VBAC. It's really something that we, obviously if like it's safe, um, to do, then we're supporting it. If your medical team is in support of you having a VBAC, like we're like, let's go. Um, so I was really hoping to do that. Ended up being induced because I didn't go into labor and I was pretty far along. I was 41 plus weeks at that point. Um, was induced and then things just didn't go well. BB's heart rate wasn't like where it needed to be. So they were, baby was in distress, ended in a C-section. So that was my second C-section. Again, obviously not what I envisioned. I was really hoping for that VBAC, but luckily I knew I had the tools. I knew what I needed to do and I just did those things. So definitely challenging. But in the moment, I'm like, whatever is going to get this baby safely out in a healthy, safe way, that is my priority. And that I think it's really hard to just tell people like, well, your baby is healthy and safe and it's fine. Like everything turned out fine. It's still traumatic and it can still be emotional and extremely traumatic to not have the birth you envision. But I really encourage all of my patients and any friends who I speak to about this to be open minded. I mean, you have this vision for your birth, you have no control. There's a lot to do to prep the body for a vaginal delivery. Ultimately, it could be the cord wrapped around the neck or the positioning of the baby via your there is just so many unknowns and so many things that we can't control. So I think understanding all the options of what could happen is really important to go into the birth with. I think being optimistic going into your birth is important. You don't want to go in so anxiety, with tons of anxiety and fear. But I think understanding these are the things that could happen. I can end up with a grade 4 perineal tear. I could end up with a C-section. What does that look like? I think preparing yourself is going to more as much as you can, sort of maximally, is going to help you come to terms with whatever birth you end up having, hopefully a safe, healthy birth.
Yeah.
uh, the goal ultimately should be you and the baby end up safe and healthy. And I think keeping that perspective can help soften the blow a little bit.
Yeah.
So it should. So
Yeah.
yeah, I think that perspective is helpful. And I
Yeah.
think, I was lucky to be in this position so that I could take a step back and say, okay, it could have been a lot worse. I'm okay. She's okay. It's all okay. So with this pregnancy, we're sort of still in debates of what we're doing, if we're doing a C-section, if we're trying for a vaginal delivery this time around. So still in talks with the doctors. They still have a few weeks left to go. So we'll just kind of see how things progress over the next few weeks.
Hmm.
Um, but I'm telling myself whatever ends up happening, just want a safe, healthy, I just want a healthy baby and I just want to be safe. So
Yeah, absolutely. And Massachusetts, I'm learning this. Massachusetts is very pro VBAC in general. Is that the case?
it's a good question. I think um, the the clinic that I am a patient at right now is very pro VBAC. So people often flock to this clinic, this, organization, if they're interested in VBAC because the doctors are more it's a doctor midwife practice, and the team is very it tries to be very open-minded with VBAC. So it's really nice getting that perspective, but it really is all about like weighing risks and things like that. Um, so yeah, I don't know that I can necessarily speak to like Massachusetts as a whole.
Hmm.
Um, but the practice that I'm at currently is actually very pro VBAC. So
And they would even consider after two C-sections.
they would.
Yeah. Okay. Because that's also is unique in comparison sometimes.
Totally.
Um,
That's possible. That's totally possible. But just understanding what the risks are and making sure
yeah.
that your team is in good communication with each other as you make that decision. Make sure everyone's on the same team. That can be something
Yeah.
that you're asking your provider. You're telling me that it's that you're pro this, but is everyone on that on your team sort of is everyone on your team on board? So that's an important thing to differentiate or to make sure that you're asking.
Yeah, absolutely. Wow, that was really amazing. We just wish you only good things and that you should feel so comfortable for the remainder of your pregnancy, that your delivery should go safely and smoothly, and that you should feel good about it.
Thank you
And
so much.
um, absolutely. And I want to reiterate like something that you said. I want to just like bring that to light again, that you said it's really helpful and important for people to go in knowing all the possible different outcomes. Obviously, you don't want to overwhelm yourself too much. And like you said, you want to be optimistic, um,
Totally.
optimistic, realistic. I think that that's really powerful. And that's so much like the basis for everything that you do is really making sure that people are informed and
Yeah.
aware.
I mean, it is so true. And it's so great that you like recognize that. Like we are just providing as much education as possible to people every time they're in the clinic, especially on day one. Just like, what is this? Where does this come from? Is this normal? What is going on? So just taking a step back, talking about the anatomy and the physiology, um, explaining the sort of dysfunction in a way that they can understand, anyone can understand. So
Yeah.
it's really, patient education is extremely, extremely important to physical therapists, whether you're a
Yeah.
pelvic floor PT or not. It's really, that's huge. So if you're, another little tidbit is like, if you leave all confused after your first visit, you shouldn't leave confused. You should leave with an understanding of what's going on with you. Um, you deserve, and everyone deserves that. Everyone deserves to have that education and to have that broken down. And hopefully, if that's, you can speak up and ask for clarification if you don't understand. But anyone who has any sort of, whether it's pelvic floor, orthopedic, whatever it is, neurological issues, deserves to have that explained as thoroughly as possible, so that you can understand what's going on and how you can take charge. What does that look like? So that is not a privilege. That is something that every person deserves. No.
Absolutely. I was really also thinking, I'm like, this really applies to orthopedics,
Oh, yeah,
medical care in general. Like you and your colleagues like sound like just amazing. And you
really
you have
lucky.
like you've explained everything so beautifully and so well. It's so clear that you must treat your patients with so much respect and also with just like the understanding that they are smart people as well, just not in your field and don't know everything.
Complete completely.
So they're really lucky to have you. So
Oh,
thank you for being here. And
thank you so
oh
much for having me. How fun.
yes, of course you were phenomenal. And how can people reach you? I'm sure people are going to want to reach out to you, even if they're not local to you. Like you're just approachable and so
Totally.
knowledgeable.
And I hope that people come, find me with questions or, anything specific. But in terms of my email is Rachel, Rachel at momlifehealth.com. Feel free to shoot me an email with any questions. We do offer like virtual sessions. It's really not super common, because getting our hands on your body is really important to us. But you know, even before that, just talking sort of via email, I'm happy to discuss, giving you some resources, helping you, just with some general information to get yourself started. Um, I'm happy to do that. So I would love for people to reach out if they had any questions about anything we spoke about, anything in general that they might be going through. Absolutely.
Wow.
So,
Thanks, Rachel. Thank you
of
so
course, thank
much.
you for having me. It's
Amazing.
been amazing.
Absolutely.
Such an amazing time. So thank you.
Yeah.
You too.